Thanks so much, Joel. It's a real honor to be speaking here today, and my talk is titled Registries and Psoriasis and Industry Perspective. First, this disclaimer that some of the content may reflect my opinion and not necessarily represent the opinion of Janssen. Now, when evaluating therapeutic agents, there's a spectrum of sources for data generation ranging from randomized clinical trials, RCTs, to registries, to other data sources that April just spoke about, each of which has certain advantages. So for example, RCTs are typically conducted under highly controlled experimental settings. Patients are randomized to specific treatment groups to reduce bias and confounding factors, giving rise to very well-balanced and evenly matched treatment cohorts. Outcomes and data are recorded and measured in a very rigorous manner, allowing for effective demonstration of cause and effect of an intervention. And registries are typically done in an observational setting and therefore provide more of a realistic representation of clinical practice. They tend to have less rigorous inclusion and exclusion criteria, allowing for enrollment then of larger numbers of patients that can be followed over a longer period of time as well, and also allows for surveillance of any potential delayed side effects or rare adverse events. At the same time, given advantages may translate into certain disadvantages. So for example, in RCTs, they're typically designed to enroll more limited numbers of patients who are observed over a shorter period of time. Again, rigorous inclusion and exclusion criteria give rise to highly selected patient populations. Also, the study environment may not necessarily represent a realistic clinical practice, and overall, results that come from RCTs may not necessarily be as generalizable to the typical disease population. While in registries, there is no randomization of patients to certain treatment groups, which may predispose to various confounding factors, and also typically patient compliance, adherence, and retention are lower. So in essence, there is no perfect data set for evaluating the performance profile of a therapeutic agent. And therefore, it is really important to consider a broad range of data sets, recognizing their respective strengths and limitations. However, concordance of findings leading to similar conclusions across diverse data sets is extremely powerful in understanding the true benefit risk profile of a therapeutic agent. Now, towards this, registries are of great utility and from an industry perspective serve two purposes. One, to address post-marketing regulatory safety commitments to better understand identified risks, potential risks, and previously unrecognized risks, but also to assess the real-world performance profile of therapeutic agents based on a broad range of parameters, including things like effectiveness, safety, persistence or drug survival, and health-related quality of life. Now, I'd like to talk about Janssen's SOLAR, which stands for Psoriasis Longitudinal Assessment and Registry, as the context for some of the themes that I'd like to share today. Now, SOLAR was established in 2007 to fulfill a regulatory commitment to conduct post-marketing safety surveillance for Janssen's biologics in psoriasis, infliximab, and ultimately ustekinumab. SOLAR was designed as a disease state registry. So not only were patients enrolled who were receiving Janssen's biologics, but really patients receiving all available biologic and non-biologic therapies. And as a disease state registry, data from SOLAR helps address information gaps on the natural history of disease and its various treatments, as well as the need for long-term data on biologics, and also provide perspective for safety data for Janssen's biologics relative to safety data from other systemic therapies. And very importantly, SOLAR was designed in collaboration with and is governed by academic steering committees to increase scientific merit. Now, SOLAR is an international longitudinal observational study that evaluates safety and clinical outcomes in adult patients with moderate to severe psoriasis. And as a real-world observational study, inclusion and exclusion criteria are very simple. Patients must have a diagnosis of psoriasis and be eligible to receive systemic therapies, be 18 years of age or older at the time of consent, and agree to be compliant with follow-up visits on an every 6-month basis. And also, SOLAR is a very large and a very ambitious project with targeted enrollment of 12,000 patients, each of which plan to be followed for 8 years. And a couple of milestones are listed here. The last patient was enrolled in SOLAR in June of 2013, and the last patient completed SOLAR in July of 2021. Again, as a real-world observational study, SOLAR has a non-interventional study design in that patients are not randomized to treatment groups, but rather physicians prescribe treatments based on usual clinical practice and standard of care with no restrictions. So again, SOLAR represents real-world experience with psoriasis treatment. And there's a vast amount of data that's generated in SOLAR, and data are collected at baseline and at 6-month intervals. However, serious adverse events and adverse events of special interest and pregnancy reports are collected and evaluated on an ongoing basis. And again, a tremendous amount of data collected through SOLAR, including things like patient clinical characteristics, medical history, including psoriasis medications, safety information, disease information, including historical and longitudinal psoriasis status, quality of life metrics, and socioeconomic data. Now, one of the more critical points that I'd like to make here is the importance of collaboration between academia and industry in conducting registries. Now, again, SOLAR was designed in collaboration with and is governed by a global steering committee whose main responsibilities are to define and execute the mission and scientific objectives of SOLAR and oversee the analysis, evaluation, and publication of aggregate data from the database. And the steering committee is comprised of 4 subcommittees to oversee specific functions of the registry. So there's an executive committee that provides guidance and oversight on the execution of SOLAR's mission. It coordinates the activities of the other committees and addresses steering committee policy with structural issues with Janssen. There's an operations committee that addresses the need for patient retention measures. It maintains investigator, study site, and patient engagement. It also maintains and encourages quality control of data collection and reviews materials to support the registry. The Publications Committee establishes publication guidelines as well as publication plans and priorities. It reviews publication proposals and oversees submissions to scientific meetings and journals. And the Scientific Advisory Committee establishes guidelines for submission of study proposals. It ensures scientific rigor of study proposals through a very robust review of statistical analysis plans. And in addition to the Global Steering Committee, there are Canadian and European regional steering committees that oversee and manage regional SOLAR activities and interests. And representatives from both participate in and contribute to Global Steering Committee meetings, subcommittees, and overall activities. Now, again, a tremendous amount of data generated by SOLAR, and data are analyzed and disseminated for 2 primary purposes. One, to address post-marketing regulatory safety commitments, and second, to inform academic topics of general interest and relevance. And I'll discuss these topics briefly, starting with post-marketing regulatory safety commitments. Now, analyses for safety surveillance for signal detection purposes are reported as unadjusted cumulative incidence rates per 100 patient years based on 2 types of safety analyses that are based on 2 different definitions of exposure. First, analyses based on whether a patient was ever exposed at any time during the registry to a given therapy to capture the potential long-term impact of exposure on a specific adverse event. And the second, analyses based on whether an adverse event occurred within the 91 days following the last administration of a dose of a therapy to capture the potential short-term impact of exposure on a given adverse event. Now, given that so many patients were followed for such a long period of time in SOLAR, that there had to be some set of rules for defining our treatment cohorts and also for attributing adverse events to specific therapies. And over the course, again, of the registry, again, many patients would switch. Now, given that SOLAR was designed as a mechanism for safety surveillance for Janssen's biologics, the following attribution rules were used. If a patient was ever exposed to ustekinumab, safety events would be attributed to ustekinumab. If a patient was ever exposed to infliximab but not ustekinumab, safety events would be attributed to infliximab. If patients were ever exposed to etanercept, adalimumab, or other non-sponsored biologics but not ustekinumab and not infliximab, safety events would be attributed to those biologics. And if a patient was never exposed to a biologic, safety events would be attributed to the non-biologic cohort. And again, SOLAR was designed for safety surveillance for Janssen's biologics, so the attribution rules are biased against ustekinumab and infliximab. Now, in addition, multivariate Cox analyses were performed for signal detection purposes to identify potential predictors, including treatments of adverse events of special interest, including mortality, major adverse cardiovascular events, malignancy, and serious infections, comparing ustekinumab alone to no biologics, other biologics to no biologics, and ustekinumab plus other biologics to no biologics. And comparisons were also made between immunomodulators and no immunomodulators. And importantly, given the nature of these comparisons, the attribution rules that are biased against ustekinumab do not apply to the Cox models. Again, I want to reiterate that SOLAR was designed as a signal detection registry using pre-specified methodology, and that study protocol stipulates that any safety finding identified should be further evaluated based on appropriate post-hoc analyses to determine if the finding represents a true safety risk or not. Now, in turn, regulatory commitments require interim analyses of SOLAR data to be provided to health authorities, typically on an annual basis, in the form of interval safety registry reports that summarize cumulative data from the registry from the start of the registry launch through the most recent annual database extraction. And safety data are also reviewed with the steering committee at regularly scheduled meetings. Now, again, as a disease state registry, SOLAR generates a tremendous amount of data that can also inform academic topics of interest and relevance. Towards this, steering committee members are assigned to sub-teams to propose and direct analyses based on topics of general interest. Also, steering committee members may propose their own studies or suggest proposals for data analysis in collaboration with external individuals or groups. And all proposals are evaluated by the steering committee for merit and feasibility through a very rigorous process that's directed by the scientific advisory committee. All proposals require a full description, including hypotheses and analytical plan, which is predefined. However, altered or additional data analyses may be requested during the review process in order to ensure scientific rigor by the scientific advisory committee. And this has been a very effective and remarkably productive process so far, with now 22 manuscripts published in the dermatology literature on both safety and non-safety topics as listed here. And many of the manuscripts have been published in the top tier dermatology journals. Nonetheless, there are many limitations to SOLAR and some lessons learned that are important to share. As with any large observational real-world registry, SOLAR is subject to all kinds of forms of bias. Also, cumulative incidence rates, as I mentioned before, for serious adverse events are subject to attribution rules that are biased against ustekinumab and infliximab. And differences in demographic and disease characteristics among treatment cohorts and incomplete capture of potential confounders may also affect results. But perhaps the most important lesson learned is that observational studies require ongoing evaluation and possible adaptation to ensure that study design and analytical methods continue to be appropriate in order to yield valid results through the life cycle of the study. As over the long-term course of SOLAR, key methodological limitations were identified, indicating that initial design features of the registry may not support adaptation to the evolving treatment landscape or account for changing patient characteristics due to switching of therapies. Now, over the course of the registry, 4 major methodological limitations and pre-specified analyses were identified. First, inclusion of prevalent users, so basically patients who had initiated their biologic therapy before enrollment into the registry, so patients for whom we don't have true baseline characteristics or disease severity characteristics at baseline, thereby limiting the ability to adequately measure and adjust for disease severity between groups at baseline. Second, there were notable imbalances between treatment cohorts. Again, patients are not randomized to receive given therapies, and baseline differences in demographic and disease severity characteristics were observed, especially between the ustekinumab and non-biologic cohorts. And not only were there imbalances between treatment cohorts at baseline, over time, the treatment groups continued to diverge, especially as patients in the non-biologic cohort switched to biologic therapy. So in essence, several years into the registry, those patients still on non-biologic therapy had relatively stable disease and were relatively healthier compared to patients in other treatment cohorts. And in turn, the Cox model does not account for differences in patient clinical characteristics at the time of switch in order to address this issue. And lastly, there was limited collection of some clinical data after registry entry, in that several health parameters relevant to certain outcomes are not collected after enrollment or not collected at all within SOLAR. So for example, relevant data not collected after baseline include new or worsened comorbidities and concomitant non-psoriasis medications. Now, to address these limitations, 3 analytical solutions were introduced on a post-hoc basis. First, use of an incident user only analysis. So in essence, only patients who initiated biologic therapy on registry included. So in essence, patients for whom we have true baseline disease severity and demographic characteristics at the time they start biologic therapy. Second, use of a modified Cox model analysis incorporating propensity score adjustments to not only measure, but then better adjust for disparities in disease severity and patient characteristics between treatment groups to allow for more fair comparisons. And then third, use of a more comparable active comparator instead of the non-biologic cohort, namely an adalimumab cohort, which had disease characteristics and patient characteristics much better balanced, much better matched with the ustekinumab cohort. Now, unfortunately, there was no solution to mitigate the limitation of limited collection of certain clinical data after registry entry, because these data could not be derived retrospectively. Now, at this point, I'd like to introduce SOLAR 2.0, which represents an extension of SOLAR to fulfill regulatory commitments to conduct post-marketing safety surveillance for guselkumab in psoriasis. And two new cohorts are being enrolled. First, a guselkumab cohort of at least 2,000 new patients, and second, a cohort of IL-17 inhibitor patients, and up to 2,000 patients being enrolled in this cohort. And these cohorts are being enrolled in the US and Canada, as well as various countries in Europe and Asia Pacific. And importantly, the lessons learned from SOLAR are being incorporated into SOLAR 2 with greater focus on incident users and incorporation of propensity score models or adjustments into the Cox model, and also use of a more appropriate matched comparative cohort, which is really one of the primary reasons that the IL-17 inhibitor cohort is being enrolled in SOLAR 2. An estimated study completion date is December of 2031, essentially extending the life cycle of SOLAR to 25 years. With that, I'd like to end on more of an aspirational note here and discuss some potential opportunities across registries, given that there are so many high quality disease state registries worldwide, and some of these are listed here, and apologies to those that aren't listed here. Are there opportunities for collaboration across registries to address perhaps larger questions beyond which any one registry might be able to address? So, for example, questions around rare safety events or outcomes for patients with a cancer history who are receiving biologic therapy for psoriasis, or questions around pregnancy outcomes or the impact of biologic therapy on development of comorbidities. And is there a manner in which data could be pooled across registries and analyzed then using agreed upon methodology? And is this the type of initiative that some independent organization, perhaps the IPC, could take on to drive? So with that, I will leave you with this summary of the major themes that I wanted to communicate today. Again, the importance of a broad range of data sets when evaluating therapies and their performance profile. Again, there is no perfect data set. Second, the importance of disease state registries, enrolling a broad range of patients, receiving a broad range of therapies, and collecting a broad range of data. Third, the importance of the collaboration between academia and industry in conducting registries. Fourth, how data are analyzed and disseminated to address regulatory safety commitments, as well as inform academic topics of interest and relevance. Fifth, important limitations and lessons learned, in particular, the ongoing evaluation and possible adaptation of study design and analytical methods, very important in order to be able to adapt for the changing landscape of treatment in psoriasis, as well as for the divergence of treatment cohorts over time. And last but not least, again, are there opportunities to collaborate across registries to address even larger questions beyond which any one registry may be able to address? So I will end there, and thank you very much for your attention.